Thank you all for coming. This one's going to focus on exercise and body composition. In the last talk, we talked a little bit about metabolic dysfunction and mitochondrial dysfunction and how that relates to aging and chronic disease. And that people that, especially in the United States or in the West, because of lifestyle and just dietary and environmental exposure, are at higher risk for these things. And just to recap that, metabolic syndrome is related to insulin resistance, visceral adiposity, which is mainly organ fat, and atherogenic changes in the blood vessel walls accompany that, and endothelial dysfunction. So the blood vessels feed all your organs, and so when they're not getting good blood flow and the nutrients that they need, the tissues aren't functioning optimally. And as we age, that just gradually gets worse. And you can imagine that if the cells and tissues aren't, they're not getting enough energy to meet the metabolic demands for just even maintenance, mistakes start occurring. And that includes in the blood vessel walls and in the tissues themselves, like the brain. In all cases, when you meet criteria for metabolic syndrome, inflammation is an underlying driver. So there are a number of strategies that we want to employ to improve metabolic dysfunction and mitochondrial disease. And the first is to avoid toxins, and a lot of that is in our food supply. And fortunately, there's some efforts being made to change that by removing some of the toxic additives in foods. And then just the refined, highly processed nature of the foods we eat. So we want to avoid those things. And it turns out exercise and the type of exercise matters. So resistance training to try to create that stimulus that helps your muscles maintain muscle mass as you age and hopefully build muscle. And then exercise and sauna therapy help with detoxification with regard to helping you increase your metabolic rate and to help your tissues get rid of toxins and improve the energy status of cells. Also reduces inflammation. Diet plays a large role. So there are multiple different diet options, which I think we'll be talking about at a future support group. Optimizing sleep and gut health, very important. And then there are a number of prescription and supplement options that can help support your energy metabolism. And a lot of those are outlined in the MEND and RECODE protocols. And then, although there's not a lot of research showing long-term benefit in large trials, it's because there's so many variables. It's hard to do large randomized control trials on treatment programs that have multiple variables. So this is an important slide, and we may refer back to this later in the talk. But the takeaway from this study is that loss of muscle mass, also known as sarcopenia, a common and normal part of aging, that is modifiable. So we want to maintain and retain as much muscle mass as we age as possible. And that is not just weakness, because you can lose muscle mass and still have pretty good strength. But muscle weakness is also very important. And when we see muscle weakness, even if there's not a lot of sarcopenia, that's a concern. And often loss of muscle, loss of strength leads to bone loss. And there are a number of studies, large studies looking at this data. This one in particular looked at about 5,888 older folks for about 12 and a half years. And you can see here that if we look at patients who have relatively normal body composition and that they're not obese and they don't have sarcopenia, so those patients fall along this black trajectory. So at the beginning, 1.0 means there's a 100% chance you're alive. And as time passes, the risk of dying increases. So at 12 and a half years in this population of, mostly 75 plus year old people, this is older people, that the risk of dying increases, and that as you age into your 80s, there's maybe a 40% chance that you might die, even though you don't have any problems with sarcopenia or obesity. But that's the best line. You want to be on that line. And then we want to find new technologies and ways to support a more youthful metabolism so that you actually can maybe move that line up. Even if you're reasonably healthy, your risk goes up as you age. But what's most concerning is that as you add more problems to your body composition, the risk of dying increases substantially. So this light blue line, or this, I'm sorry, this orange line just below the black line represents people who are obese, but they don't have sarcopenia, or they just have one problem. Either they're obese or they're sarcopenic, but they have preserved muscle strength. And so that line is pretty close to just the normal risk of dying as you age. But as soon as you add another component, so if you're both sarcopenic and obese, then you drop significantly into this light blue line. And it's about a 8 to 10% increased risk for dying. But the most, I guess, powerful marker for mortality risk is this lighter gray line, and that's if you just have low muscle strength. And this is measured through a tool called a hand dynamometer. Some of you may have seen this, but this tool actually measures how strong you are squeezing it at your maximum effort and recording what that is. Most of the time we do it 3 times and just take the highest one. And if you have low hand grip strength, and that's defined as having 27 kilograms or less for men, or less than 16 kilograms for women in this study, then your risk goes down substantially. So, 12 years out in the study, it's nearly a 20% higher risk of dying of all causes, even though you may not have a disease per se. But all these people, as they age, could get different things. So certainly, if you have kidney disease or diabetes, the risk just keeps going up. Now, the next one down, have additional body composition problems, then the risk gets even worse. But this is a warning that if we intervene, if we change our lifestyle, change our diet, use the technologies that we know about to improve muscle strength, to improve your muscle mass, and reduce your obesity, that you can have a substantial impact on your long-term all-cause mortality risk. So this looks specifically at grip strength. They looked at elderly patients. The average age was 72 to 77. That none of these patients, when they started the study, had dementia. But they followed these people over time, and the ones with the lowest grip strength had the highest risk for dementia. And of the entire cohort, about the average age for people who developed incident 2 dementia, which means they didn't have it at the start of the study, but they developed it during the study, the average age was about 77, whereas the rest of the patients were younger that did not develop dementia, at least not yet, during the time of this study. And the criteria for grip strength was more generous than the previous study I just showed you. In that previous study, the low grip strength for men was 27, and in this study, the low was 29.2. So you could imagine these curves would be even lower if your grip strength was recorded in the same way as the previous study. And in women, it was 16 kilograms in the previous study, and this study was 18.3. So when I pass this around, you guys can check your grip strength if you're interested. This is another study that shows that, as older folks start losing their muscle mass and their strength, we can actually see that the brain is shrinking, that there are areas of the brain that are losing white matter and losing gray matter. And this study looked at that in multiple areas. And the patients who had more problems with body composition, they had more CSF volume on the surface of the brain, which means the brain has shrunk. There was more evidence of white matter changes in the brain and even cortical brain infarcts. And the number of these white matter lesions were higher. And so we often see patients, and we do at the MRI, and we see these lesions, and it gets passed off as normal for aging, but it's not normal, and it's related to this change in body composition as we age. Also, this A beta is amyloid beta, which is associated with Parkinson's disease, And we often see that that starts to accumulate in these patients, even though they don't have dementia yet. A lot of patients with mild cognitive impairment also have this early pathology that may lead to Alzheimer's. And now there are tests we can actually perform that look at that in early patients. I'll talk more about that later. So if we look at the data, and this is compiled data, looked at a lot of studies trying to determine about what is the average rate of decline in just for mild cognitive impairment. So you can get mild cognitive impairment for a lot of reasons. People that have sleep apnea or thyroid problems. There's a lot of potentially reversible causes of mild cognitive impairment. But as a general rule, the average rate of decline on the mini mental status exam, which is the MMSE, is about -1 point per year if you don't treat these patients. The scale is only a 30-point scale. And, if you score a, 25 or to 30, you still look pretty normal. But if it starts getting down to, 22, 20, 18, once this is like closer to 16 or 18, you have dementia. So 1 point per year is, serious business. If you're losing 1 point per year because you're not addressing these risks, you're probably going to develop dementia, within 10 years. So I don't think it should be ignored. Now, another thing that's interesting is that the drugs, there's not a lot of drugs none that are FDA approved for mild cognitive impairment per se, other than managing all of those things that I was talking about on the last support group meeting, treating the sleep apnea and optimizing metabolism. And a lot of those patients get dramatically better if you just address those issues. The acetylcholinesterase inhibitors are drugs like Aricept and Exelon, and these are drugs that are approved for Alzheimer's and Exelon in the case of Parkinson's. And in mild cognitive impairment, there's not a lot of studies, but most of the time you put people on these drugs and they do feel better. They can tell that they're better. It's subjective, and family members note some improvement. And so it's estimated that's considered a symptomatic benefit. But it's noticeable. It's probably only in the first year, and you're not addressing the underlying drivers. You're not addressing the inflammation or the sleep apnea or all these other potential problems that are gradually compounding and damage over time. Now, interestingly, high intensity interval training seems to be the most potent tool in mild cognitive impairment. Based on recent research, we see about a +2 to 3 point improvement in just the first 2 to 3 months. And there's not a lot of long-term studies in high intensity interval training in mild cognitive impairment, but it's thought to be a half to a point per year improvement going forward. So just getting exercise back into your life, if there isn't any, can substantially redirect the trajectory of aging and age-related risks, including neurodegenerative disease, in my opinion. So this article I pointed out last time, I'm not going to get into a lot of detail because there's a bunch of slides, but at the end of the day, a study that was done in 2006 postulated that the amyloid beta was a fundamental cause of Alzheimer's disease. And they faked that data in 2006. It was amyloid beta 52 or 56, I believe. And since that time, they've looked at other types of amyloid beta that they think are more relevant than this one. But this directed a lot of the research the last 20 years to the tune of $25 or $35 billion. And now there's a big push to promote these disease-modifying drugs. And this particular slide shows a couple of those drugs. On the left is a drug called lecanemab. And this drug, donanemab, they both work by tagging the abnormal protein, the beta amyloid, for your immune system to come in and try to clean out. And they've proven that they can do that. So a lot of the marketing for this drug is that they've shown, especially if you look at this bottom slide, that over the course of the first 6 months or so of therapy, there's a dramatic reduction from 108 they're called centilloids. This is measuring the intensity of the brightness on a PET scan of presence of amyloid in the brain, and then it drops all the way down to 7. So they successfully removed the amyloid. Now they can only do this in very early patients. So if you show up in the office, you're complaining of some memory problems, but you're still pretty functional, then you might be a candidate for this drug. Because if you have more advanced disease and there's a lot more amyloid in the blood vessels or in the brain, and you target those abnormal proteins with your immune system, The blood vessel walls break down. You start to develop edema, and a lot of times it's asymptomatic, but some patients will actually develop hemorrhages, and that can be a devastating new stroke, disability, and even death. And the risk for that is not small. It's actually somewhere between 1.5 to 3 or 4%, depending on the drug. And then the risk of having a severe side effect to the drug that's not a stroke, just from that swelling, is probably in the range of 20 or 30%. So it's a risky drug, even though it's not considered experimental. It's a risky drug. And then what are the benefits? So if we look at the rate of decline in Alzheimer's, not mild cognitive impairment, if you don't treat Alzheimer's at all, you're going to lose minus 2.5 points per year once the diagnosis is made. And these are usually, not just very simple mild cognitive impairment, but they are detecting people earlier now with a blood test that looks at the ratio of beta amyloid and tau, which are abnormal proteins that are involved in a lot of different diseases. But if the predominance is amyloid, then you get a diagnosis of Alzheimer's, even though you may not clinically have Alzheimer's yet, based on the test, and your APO4E status. You might be considered as a candidate for these drugs. But the lecanemab and the donanemab only reduce the rate of decline by about 0.7 to 0.8 per year, and there's no obvious improvement. Now, some patients do show some improvement if they're started very early in the disease, but the decline persists. So based on large trials, they've concluded that the benefit is at 27 to 35% less decline than placebo, because placebo keeps getting worse. And so the difference between placebo and being on the drug is statistically significant, but it doesn't mean you're a lot better. It just means that you're declining at a less rapid pace than not being on the drug. The cholinesterase inhibitors actually work better initially. So you could do both, but just using the Aricept and the Exelon, you decline about minus 1.5 points per year. So at least in the first year or years, the older drugs seem to work better than these newer drugs, but it's not considered disease modifying. In the sense that lecanemab and donanemab are trying to remove this abnormal protein. Now, they're doing research like this in Parkinson's too, because there's an abnormal protein in Parkinson's that misfolds and aggregates called alpha-synuclein, and they're trying to develop antibodies to target that. But I don't think it's going to be a game changer. And I'm not completely opposed to continuing this research, because if we catch patients early enough, the risk of side effects is a lot less. And you can see in the blood vessel walls, especially with amyloid accumulates in the blood vessel walls and makes the blood vessels less healthy. And they showed that they can remove that, and the smooth muscle starts to repopulate in the lining of the blood vessel walls. That sounds like a good thing to me, but it's only if there's not a whole lot of risk associated with being on these drugs, and it's still too early to say that that's going to be a good idea long term. To put everybody on these drugs like they give people statins, hoping to prevent Alzheimer's. And when you look at the data, the benefit isn't really that dramatic. So now, high intensity interval training hasn't been studied in Alzheimer's disease. Most of the data we have is from mild cognitive impairment, which is pretty dramatic. There is one study that they looked at, a relatively small randomized controlled trial, looking at high intensity interval training in Alzheimer's disease, and didn't see any benefit except for improvement in gait speed. So there were some physical benefits, but in terms of memory and cognition, they didn't see that benefit. And that might be because there's too much junk already built up in the walls of the blood vessels and in the brain, and just exercising doesn't dramatically reverse that, at least in this short run. That study wasn't a very long study. It was pretty brief, actually. So the Mend and Recode protocols, which is sort of doing everything, throwing the kitchen sink at this, fixing sleep apnea, lab abnormalities, using medications, managing the blood pressure, everything, changing the diet. That's the first thing. Optimizing sleep is one of the top things that are recommended. that at least in case series that have been published, there's a 25 to 30% improvement, but it's not robust data. And it's, like I said before, it's going to be hard to do a large randomized controlled trial when you're doing so many things at the same time. But it is encouraging. And I've seen these improvements in patients in our practice where we address as many of these issues as possible, which is part of the reason we switched to the model that we currently operate under, so that we have the time to identify these issues and address them. So Parkinson's is actually more responsive to treatment than Alzheimer's in a couple of different ways. Now the scales, just to explain them, UPDRS-3 is the motor scale portion of a larger test, and it has 108 points as a maximum score. In an untreated patients, they generally get worse. Higher numbers mean you're getting worse by plus 3.33 points per year. Now, most people with very minor symptoms, they might have a part 3 motor score of 6 or 10. If it's moderate symptoms, it might be 25 to 30. And if it's more severe, it's probably more like 50 to 60. So 108, I've never seen a patient that was alive that had over 80. Usually if you're that bad. So taking that into consideration, if we treat patients with just medications, we see continued decline, but in the off state. So you give people medicines, they look a lot better, but you take the medicine away and you just see what they look like compared to patients that were not treated. There is a disease modifying effect in being on medications. Part of that is if you don't use it, you lose it, right? So if you're not on medications, you don't move. If you have a lot of tremor, the medications affect your mood, you're apathetic, you're not motivated to do things. So you end up being more sedentary and more disabled. And if you're like that, the disease is more rapid, okay? But if you're on medication, symptoms are better controlled. There's some theories that some of these medications might help in other ways, but it's really on the margin. Now, the third one is ST&DBS, deep brain stimulation. We primarily do that in the subthalamic nucleus, plus the medications. Now, and we usually reduce the medications by half. If the leads are well placed, medication requirements go way down. Sometimes we eliminate drugs. We have patients that don't require any drugs, and they look very good. So the initial improvement on this scale is minus 22.1 points. And if you consider the placebo group never gets to 108, it's really like a 50.5% on average improvement in the UPDRS-3 compared to placebo. And then stipulate you still get worse, but from a much better baseline by about plus 2 points per year, and that's leaving the stimulation on with no medications. You add the medications in, they still look better. So we think that patients who have DBS earlier, there may be a disease modifying effect where you're actually slowing down some of the progression of disability versus not having DBS. And there's some basic studies that look at that. I mentioned at last support group that the mitochondria are more normal and they're more numerous in DBS treated patients in the area of the brain that's being stimulated, which is very important for physical disability in Parkinson's. Now, you look at the next one, high intensity interval training, and there's a study that was just published, and they have a version of intense physical training that uses virtual reality, where they have people basically playing like a video game, but your heart rate goes way up into that high intensity range. That these patients also see dramatic improvement, and it's a different scale. It's a UPDRS. It's a daily living score. It's got 52 points, so it's not 108 points. And there was another study that did look at UPDRS-3 that kind of correlated. They mentioned that in the study, but it's basically a 50.5% reduction in your motor activities of daily living are better, 50.5% better. And that's without doing DBS or meds, right? So you combine the two and you might look pretty normal. And some of our patients do. So I think that that's pretty compelling. Now, they didn't look at cognitive data in that study, but I think there are lots of basic reasons, growth factors like brain-derived neurotrophic growth factor, improving blood flow, all kinds of benefits to exercise that are going to help cognition, even though we don't necessarily have a big study to tell us that. I feel pretty confident that that's the case. So we encourage, everybody to exercise, and that needs to be individualized depending on individuals' current disability. What kinds of exercise can we come up with that will create that level of stimulus that's going to result in a better long-term outcome? And then coaching to get people to keep doing it. So the MEN protocol in Parkinson's hasn't been studied. It's just really the case series are only in Alzheimer's patients. But I think a lot of the basic concepts apply, that if we improve all of these things, reverse metabolic syndrome, improve body composition, that we're going to see dramatic benefits in Parkinson's patients too, especially when you consider exercise as one of the biggest components of these protocols. That we are going to see improvement. Is it going to be more than just doing high intensity interval training by itself? Probably. Okay. But again, it's hard to do those studies. So this is one of probably the most important new study. It was published in 2019. But it shows, if you look at the upper left slide, this is that motor score, the activity of daily living score, and you can see the placebo is the top line. That at the beginning of the study, in the darker gray band is where they did the exercise. And they didn't do the exercise in the placebo group on the top line, so they're at 0, and they just get worse as expected. This is a 2-year study. So this correlates with what I had in my other slide, that people get worse about 3 points per year if you have Parkinson's and you don't do anything for it. And they didn't change the medications during the study. So this shows the medications in all 3 groups stayed the same. So this is the time to get up and go. So this test, basically, we have a patient sit in a chair. We time them. We ask them to stand up and walk as safely and briskly as they can, about, I think it's 10 meters around a cone, and then come back and sit down and time it. So you can see in the placebo group, there was no change over the entire course of the study. But in the group that exercised hard for 3 weeks and stopped exercising, they improved. Eventually, they caught up with the placebo group. But the group that exercised the entire time stayed the same. So I think that's pretty compelling data. So this is another study that looked at Parkinson's doing high-intensity interval training. It was a shorter study, and it was a 10-week study. And they looked at VO2 max, which is a measure of what is your maximum oxygen consumption during the most intense exercise that you can do. So they actually made these people do this, which is hard. And some of our patients just can't even do it because it's hard. But they had these patients do it, and they could see in the high intensity group that there was a significant improvement in VO2 max just over the course of this 10-week study. And so that's another metric, like hand grip strength, that correlates with mortality risk. So this type of exercise has profound effects, not including how you exchange oxygen during exercise. And that's important for when you're not exercising, just rest, walking up and down stairs. And that is influenced by not only by exercise, but lean body mass and anabolic hormones like testosterone, estrogen, these kinds of things. And the decline in growth hormone as we age plays a significant role in this. There are indications that loss of growth hormone, if you can supplement growth hormone, your VO2 max starts going back up, even if you don't change your exercise routine. So this is what doing a VO2 max looks like if you do it the hard way. Usually it's on a treadmill. It can be done on an exercise bicycle. But you basically have to go as hard as you possibly can to reach your maximum heart rate. And this is difficult to do. It also requires expensive equipment. So what we've decided to do here is a validated alternative. It's called a submaximal VO2 max test, where we have patients get to about 70 to 85% of the maximum heart rate for their age using an assault bike, which is it's a glorified exercise bicycle, but it measures the amount of energy you're producing during that exercise. and we keep your heart rate steady in that upper range, but it's not that hard. It's not as hard as actually trying to do a VO2 max test. So most patients can do it. And in this patient, you can see we did her on April 22nd and again in May 27th, and she improved, but just doing exercise with us and following our treatment plan, she improved from below average to above average. And if this is another Kaplan-Meier curve that shows mortality risk. So if you're in the low group, your chance of dying in 10 years is about 78% chance that you'll be alive. So that's 22% chance that you might die if this is the only thing you're looking at, right? So you really want to be in these upper groups. But even here, we can use this as a measure of fitness. And so we want to see that improving and trying to get people up to the higher levels. And it's doable, as was shown by this example. So this is the grip meter. I'm going to pass this around so you all can play with it. So all you do is you squeeze it as hard as you can, and it tells you what the maximum that you did, 103 pounds. I'd rather set this to kilograms because that's what my next slide is going to be about. And so we also like to do a DEXA scan. DEXA scan is really the only way you can measure visceral body fat. It also looks at your bone mass. And it can give us some idea of what the distribution of lean mass is. And that gives us some data that correlates with risk. So we don't do this all the time, but I think all of our patients, at least at the beginning, will get a DEXA scan. So this is actually Mr. Crosnow's DEXA scan, which he lives about 2 hours away. So we went to a different center, and I was kind of pleased to see that they looked at the appendicular lean mass. They calculated it for us. Now, in that study that we looked at toward the beginning that showed the mortality curves, that one of the findings for sarcopenia is this appendicular lean mass index. So in men, you want that to be, I think it's 7, more than 7. So he's 8.6, so he's good. But in women, I think it's 5.5. So it's nice to know that, and this is the only way to really measure that. Visceral fat is also important. So yeah, I need some work there because that is also linked with higher risk inflammation and damaging blood vessels and organ tissue. And the bone mineral content, so this gives us some idea of what the risk is. If the bone mineral density is kind of low and they're high risk, then we might do an actual bone scan that looks at the hip joints and the vertebrae. He's in a good spot. We just want to see that improving. So this is the DEXA scan that we use a center here in Austin because they give us a good deal. They do not measure the appendicular skeletal mass index. So we decided to, I did that based on that study. And so you can see here I'm 8.8, so I'm not that much higher than Mr. Crosnow. But I think the goal that was, most average healthy people are in the 8.59 range. But if you can get higher, build more lean mass, it's like putting money in the piggy bank. The more you can maintain that lean mass, the better. So what are the kinds of exercises that will help in this regard? If you can play the jump chin-ups, this was a study I might get into on a future support group, but this was done in elderly women in their 70s, somewhere in their early 80s, using this type of Smith rack. You can, control the movement and try to do it safely. But this is an impact exercise, and that really does stimulate bone density as well as muscle development. So doing some kind of impact exercise, usually with supervision, so you don't hurt yourself, is important. This is the assault bike, which you can really go really, really fast and get your heart rate up very quickly with this. So you can do high intensity interval training in a pretty short period of time. The studies, it was 20, 25 minutes of high intensity interval training. You do that 3 times a week, you get this benefit. So it's not really that hard it's hard to do, but it's not that time consuming. You just need some coaching, and that's what we try to do here. Now the low bar squat, I think this is just for the talk, but using a Smith rack, and most of our patients aren't going to be using a bar yet, but just doing that with your body weight is sufficient. And then deadlifts, you can also do that with your body weight. Just use a light stick to start, and then just gradually add weight. But the stimulus from these types of exercises are very effective at improving bone density, much better than the drugs that we prescribe, and much safer actually. So these are all considerations. Well, thank you all for coming. Hopefully it was enjoyable and worthwhile. Thanks, guys.